the COPD has been more or let's say a disease which is medically managed, and surgery was more or less end stage if you're going for transplant, or crisis management when people develop pneumothorax and the medics cannot manage it. But recent developments in the field of this disease have made it a bit more interesting as a surgical sort of disease, as a surgically managed disease. So hopefully all of you have learned at some point the respiratory anatomy, and we know that there is two main components. There is the anatomical sort of the conductive system, which is the bronchus and the airways, which allows the air to travel down all the way to the parenchyma. And then there's the work of respiration, which happens in the alveoli. And then there is the mechanism which is driving that movement of air in and out of the lung, which is the ribs, the intercostal muscles, and the diaphragm. So this is a bit of a practical knowledge about the anatomy. Now, getting into the air, into the chest has two ways. Obviously, the bronchial is a natural orifice way, which we will talk about later on. And then there is man-made holes, which is the cuts we make inside into the thoracic cage to get into the lungs, and that can be through a median stenotomy, a thoracotomy, a video-assisted thoracic surgery. So there's a few approaches there. So from a bronchoscopy point of view, and you can see here on the picture on the right, where you have your trachea, right and left airways. You can see here on let's take this out of the way. You can see here the view as we see it from a surgical approach. Now, the medics, you might have seen, stand at the bottom facing the patient. The surgeon usually do their bronchoscopy from the top because we do it under GA through the ET tube. So the view we have is slightly different. So on here, what's at the right and left are very anatomical, while if you while the pictures here may be sort of showing you the right on the left hand side. So bear that in mind when you're looking at this and looking at that. So in this picture, you can see the left upper, left lower, right upper, bronchus intermedius, and down bronchus intermedius, you see how it splits into a middle lobe bronchus and a lower lobe bronchus. And diametrically opposing the right middle lobe is the apical segment of the lower lobe. In the left, obviously, we have slightly similar arrangement between the left upper lobe proper and the lingula, which is equivalent to the middle lobe on the right. So I know it's confusing, and it's one of those things you need to see a few of, and then you will know. But one of the things about surgery and imaging is that ability to use both hands and both sides of your brain and image things in a variety of ways gives you more dexterity in managing. Imaging is becoming key in terms of intervention, whether it's surgery or other interventions. And I'm saying the word intervention in the widest sense because from a surgical point of view, as cardiothoracic surgeons, we are more and more moving into the minimal invasive, minimal access domain, and we relying more on what we see rather than what we feel, which is an interesting way of tackling disease nowadays. People think of surgeons as people technically working with their hands, but now we're working with our eyes more so to reach our targets. So going now into the main main talk, just a bit of a background. Obviously, this is something you might have picked up in your medical school. COPD is one of those chronic long-term conditions, is with occasional exacerbations. It's quite a wide disease. Now, these numbers and figures are not up to date, but they are in the last decade or so. you can imagine this problem is going to be worse. So the burden of that disease in terms of health, money, health finances, NHS, societal, is quite big because it's not short and sharp like cancer or infection. It's long-term, over years and years. So it drains the patient, drains his family, it drains the economy. Most of the ITU patients who are admitted to ITU are admitted with respiratory problems, exacerbations of COPD and other respiratory conditions. So it has a bigger footprint than you can think of, and it is a silent disease. So a lot of people do not notice it until they're quite way in advance, and or fall into a complication. It is caused mainly by smoking. There are other environmental factors. There is an element of infection, inflammation, and immune response, which help for the disease development and what kind of subtype of that disease. There is some genetic element, in particular, some of the variants like alpha-1 antitrypsin deficiency, which has a particular distribution and presentation. There is two broad sort of, under the umbrella of chronic obstructive pulmonary disease, there's two main diseases, but my physician colleagues who I work closely with tell me there's about 12 variants now. So this is very old. Now we know that there is far more subtypes under these, and with a mixture of airway emphysema and airway and parenchyma, and reactive airway and non-reactive airway, and inflammation as a main component, or infection as a main component, and a different immune response. So if you put all these things together, you end up with too many categories. Just put in bold here the one which is of interest to us as surgeons at this point of time, though we are going to be expanding into the other subtypes, but that's got to be beyond this talk at the moment. So if you're looking at emphysema as a subgroup, big subgroup of people with COPD, you can see here, as we're looking on the left-hand side, that the lung is normally made out of this spongy thing, which is similar to the normal sink sponge, made of very small alveoli, has very thin wall with a big surface area. And the usual description is that if you open up a lung alveoli, you cover a tennis court. So that surface is important because the blood which is running in the vessels around the alveoli is what help the exchange, the respiratory exchange of gas and gases, in particular oxygen, between the alveoli, air, and the blood. So the more of those great little things, the more surfaces we have, the more easier the exchange happens. What happened in emphysema is, this is what we are looking at, is where we end up with a sea sponge, which has big holes in it, other than the sink sponge. And that big holes mean that you have lost a lot of air surfaces, surfaces where air is in contact with blood. And this is basically what it looks like. Now, the bigger the loss of partitions, the bigger this bag of air is, until it becomes macroscopic. You see them on a normal X-ray, and sometimes it can take over the whole lung. So it goes from emphysema to blebs to bulla to massive bulla or giant bulla, where the lung is basically disappears and you end up with a big air sac. Now, the problem with this as well is that when you have a big balloon, deflating a big balloon is more harder than deflating a small balloon. If anybody think about the air wrapping, the bubble wrappings of any kind of fragile things you have in the box, it's easier to pop these, and you have millions and gazillions of them, compared to a big balloon. Emptying a big balloon of air compared to emptying one of those small ones is far more difficult. And that loss of elasticity which happens is one of the factors in the pathophysiology of emphysema. So in addition to the loss of surface, we're losing the ability to empty out those sacs of air, which is extremely important. So if you go then more into the pathophysiology, which I started talking about, is that there's this degree of air trapping which happens inside the lungs, which is static but dynamic as well. As patient draws more air in, they find it difficult to breathe out. So the problem with emphysema patient is that they don't empty their lungs out, and their breathing pattern sometimes aids to their problems. And that is the reason why they end up with this barrel-shaped chest, which we all hear about and see in some of those patients, as they lose the ability to squeeze the air out of their chest, or they don't know how to do it. This is where rehab comes in as a way of dealing with emphysema, and in preparing patients for interventions. It's important to train them to breathe out and reduce the amount of dynamic hyperinflation. There is a vascular impairment because obviously with more air inside the chest, you raise the venous pressures, and also you limit the amount of flow of blood into the lungs, because there's less surface area for the blood to travel down. These cause something called pulmonary hypertension, as a reduced amount of blood flow through the lungs. You still have 5 liters of blood, which has to travel now through a smaller or a more shrink network of roads. Therefore, there's extra pressure going through that on the heart. There will be areas of the lung which are not going to get blood, or if they're getting blood, they're not getting air, and therefore you end up with gas exchange abnormalities, and VQ, ventilation perfusion. V stands for ventilation, Q for perfusion. And we know that people go from hypoxia, from hypercapnia to hypoxia as the main respiratory drive. So that's why one of the reasons why we don't give patients with COPD who are having problems with exacerbations too much oxygen, because you stop them from becoming hypoxic, which is the main drive for them to breathe. So we have to be careful about that. Also, there is an element of mucus hypersecretions, which is not as bad in emphysema compared to bronchitis. Still relevant, but it can add another layer of, or another barrier to those alveoli. So this is just an explanation of hyperinflation, and so there's a static hyperinflation which happens because of the anatomical reasons we discussed, and then there's the dynamic hyperinflation where patients do not empty their lungs, and if they shallow breathe rather than give more time for exhalation, they will start to trap more air in. And the classical sign on the X-ray is you see the diaphragms are flattened, the intercostal spaces are horizontal and quite splayed out, and you see the mediastinum quite narrowed in the middle. And these things can be measured in a variety of studies. So the hyperinflation is key, and you will be hearing about that in the way we assess and eventually manage patients who need intervention. So, so we just mentioned about the hyperinflation, how the breathing out is a problem in trapping more air in if it's not done properly. So presentation, again, medical school stuff. You can see the typical patient is somebody eventually will be disabled on oxygen, doesn't have much reserve, prone to recurrent infections, because if they're managing just about to breathe, coughing requires them to hold their breath to cough, and therefore their mucus hypersecretion and retention both eventually end up in having more respiratory infections. They are using every bit of muscles, and that's why you see their necks, the way they hold the edge of the table gives you a clue about them having to use those scalenus muscles, the pecs, and that work of breathing, which is normally 3% of your overall body work. If you're looking at your muscles, your heart, every part of you have a energy expenditure to do its job. Normally the lungs, if they are normal, they only need 3% of the energy expenditure to ventilate. When you have, you're trying to get as much air in or out, you're really working your muscles, it can go up. That's why you have cachexia, which is one of the things you see with advanced COPD, because they're working themselves hard just to breathe. Wheezing, when you have a component of airway reactivity, pursed lip breathing to trap some air into, like a physiological PEEP, to allow the air to stay in a bit longer. Chronic cough, barrel chest, we talked about this, we talked about prolonged expiratory time. Digital clubbing, again, mechanisms of that. We talked about how the heart as well can suffer as a result of the increased afterload over in the right ventricle from the high PA pressures. And we talked about the muscle wasting and the energy sort of loss through work of breathing. So how do we assess patients with COPD? So clinically, obviously, is the main thing. It is a delayed presentation. A lot of those smokers will not notice that they are breathless. So they only come when there is an exacerbation, a pneumothorax or respiratory failure. But once they're there, you need to go through a series of investigations. The key is lung function test. Then you go into a bit more elaborate testing as the patients go down from a primary care, which is still 95% or 98% of the patients are seen by GPs and managed by GPs. They don't see a hospital respiratory doctor until they're late or complicated or admitted through A&E with exacerbation or respiratory failure. Imaging, again, is not something which is done routinely for patients with COPD. They barely, some of them even just about get an X-ray. And then these are kind of tests which can only be done in a tertiary center where the patients are referred for potential intervention. So these are not routine. We'll talk about some of them. So the humble lung function test, which is something which in the least or the most easiest version is a spirometry, which is a handheld spirometer, which they puff in to get a puff at the GP, and they just get a number. And if that's reduced, then you go to a bit more elaborate one, which is done in a hospital. You don't see many of them in community. I don't think there is any. There is some mobile units which is starting to do them. And this is a respiratory cycle. Again, not go into the details of it. You look at the tidal volume, but the number which we are very interested in with COPD is the residual volume. This is the amount of air which is left inside the lungs after exhalation. Obviously, with COPD, FEV1 and the amount of air exhaled in the first minute is the important criteria of diagnosis. But for intervention on patients with COPD, it's the residual volume, how much air is trapped inside that lung. And the magical figure which we use is 175%. So it means that they have nearly twice the amount of air in their lung than normal, or which is basically splaying their chest and stopping them from breathing properly. So this is some imaging. Again, CT scan, as I said, is one of the ways of assessing. So you can see a normalish looking lung, but then you can start see how the damage starts to progress as you lose that kind of nice fine granular area into a bit more blackness, and it can eventually become a giant bulla like this, where the whole lung has been destroyed and you end up with slivers of lung. And it can be differential, although it could be more regional, like upper or lower, but we have different parts of the lung gets damaged differently for a variety of reasons. There's no set pattern. There is some may have more upper lobe, some lower lobe, and some mixture. This is one of the functional imaging, which again is a specialist test, which is not done and we're looking here on the right, it's called a PQ scan. And then here is called a SPECT-CT, which is single positron emission CT. So both these scans have what they call dual isotope studies. One of them is inhaled, one of them is injected. So there's a perfusion and a ventilation. The idea is that you look at where the air, radioactive gas, xenon, or the blood albumin labeled, which is traveling to. So the areas of the lungs which are destroyed doesn't have air going in and out of them easily, and therefore don't have enough blood going in them as well, because there's no circulation in that bit, will show white because there's nothing going in. The areas which are more active will show black. Now, again, here's the color coding can be different. And in this case, from a VQ scan, we go to something a bit more elaborate like SPECT-CT, because it combines this dull looking picture, which just blobs, into something imposed on a CT. So you can tell what an upper lobe, lower lobe, segment, lingular activity is like. And that helps you plan your treatment more appropriately. But the color, some scans, they may have them in purple and or different colors. But the more color you see, the more likelihood that this area is functional. The less or the lack of color means it's non-functional. It is always important when we are assessing patients to make sure that it's not multifactorial, and because if it is, then your problems are not going to be sorted out by just dealing with the respiratory bit. As I said, the number one is cardiac failure, and that could be secondary to the lung, to the lung problems, or it could be uncontrolled asthma, it could be deconditioning, obesity, alcohol infection, anxiety, and quite a long list. So these needs to be assessed before you actually tackle the respiratory component on its own. Gould is a criteria which has been a global objectives for organization for lung disease management. And it's like an umbrella body which has studied COPD and set up some guidelines, which we just talked about, basically a spirometry, and then to assess patient and symptoms to allow the patient then to be fitted into some categories. So based on the numbers we get from their spirometry, we then put them into 4 categories of Gould on numbers, 1, 2, 3, 4. But then based on the symptomatology, you then put them into groups of letters A, B, C, and D. And to confuse things further, we have 2 other classifications, the MRC, and the COPD CAT score or scale. And basically these are for deciding the level of disability or dysfunction they have. So this is spirometry, this is admission, this is amount of breathlessness and dysfunction in terms of day-to-day activity. And then there's the St. George questionnaire, SGRQT, but I don't want to put that in there. That's enough, assessment there. So this is, again, another way of looking at the Gould criteria, Global Initiative for Chronic Obstructive Lung Disease. And it just gives you what I just said in writing. So coming down to the management bit, this is a general view, and it starts with a symptomatic relief, and part of that is emergency management of pneumothorax, reducing frequency and severity of exacerbation, reducing lung injury. Obviously, smoking cessation is number 1. Then the inhalers, which could have a combination of bronchodilators and inhaled steroids. There is talk about vaccine, which has been trialed in Southampton against certain airway pathogens. pulmonary rehab to teach them about sort of using their muscles and their respiratory cycle a bit more intelligently, and occasionally oxygen as later stages develop. And the whole idea about the management is to improve the functional capacity and quality of life. Now, surgery, or sorry, let's say invasive management, is something which is this small part of the management. That big management is still medical, I would say 90% or 95%. But invasive management steps in certain conditions. It can be at in an acute setting of a pneumothorax, or at the end setting of a lung transplantation. But then over the last 20-something years, there have been this thing called lung volume reduction, which is based on the principle of trying to change the dynamics of the lung and the chest wall, and and how air goes in and out for ventilation, and then the work of respiration to better match what goes into a good area of the lung, or a less damaged area of the lung. So, and the lung volume reduction has came in a variety of interventions: surgery, lung volume reduction surgery, or a bolectomy, which is taking a big giant air sac. Endobronchial valve, which is the new, this is about 10 years now, lung volume reduction coils, which has been suspended recently, sadly, because of some company issues. And then we have some experimental treatments like steam, glue, foam, and there's other treatment, which is total targeted lung denervation, which is not purely a treatment for emphysema. Transplant as an invasive management is a rare resource. We know that transplant, which heard about the news about changing people's blood groups so that they can use more organs out there, but it is a finite resource and it's not cheap, and there's a failure rate and a mortality rate. So it is not a treatment which is widely used or available. And there are a lot of people who die or are removed from the list before even reaching lung transplantation. But within those millions of people who are suffering, there's a 6% potentially eligible for lung volume reduction surgery, but we know that only 100 procedures are done in the UK, or on average in Southampton we do about 10 to 20. So this is the number we have overall in the UK, but we know that potentially there will be 16,000 people who might benefit from this. It is a nihilistic approach by the primary care about, well, you have emphysema, is going to slowly creep up on you, and you might eventually need oxygen, and if you're lucky you get a transplant, or you may die. So sadly, a lot of people do not know that these treatments are available. So what's the rationale behind the lung volume reduction? Is to improve the diaphragm and chest wall mechanics, improve the elastic recall of remaining lung tissue, and reduce the amount of airway collapse, reduce the dynamic hyperinflation and inhomogeneity of ventilation and perfusion. So we get air, good amount of air traveling through a smaller, shorter distance to less damaged bits of the lung, which can have better blood and air supply. It's a long-winded diagram which shows you the decision tree about where would the patient fit down in this kind of going down to the treatment. Some of them will end up with transplant, some of the bolectomy, but not. This is only the patients who go down that route. We need to select the patients for the treatment. So if we get a patients referred who have disease which we think is surgical, we need to make sure that they have emphysema predominant, not chronic bronchitis. They should have hyperinflated lung. They should not have been smoking. They are functionally limited. If somebody have advanced COPD but he's able to do his life-to-life, day-to-day shows, we don't rush into surgery. We wait until they become poorly before we actually intervene, and we have excluded other causes. We optimize them for the treatment with smoking cessation, medication, make sure that their medical management is top quality. They've had their rehab program in the last 12 months. They're well fed, because obviously if they're cachectic or BMI below 20%, their risk is high. If they are on oral steroids, we try to reduce that amount as much as possible for surgery. Make sure that they have good exacerbation control, because otherwise they'll have problems with any interventions we have. And there is no other causes or problems which can hinder their recovery from any kind of intervention. These are the kind of benefits you have from LVRS. In a carefully selected. I'm saying it very much carefully, because if you look down here, the proportion of patients who respond to the treatment jumps from 20% in unselected group to astonishing 75%, which I'm glad to say that Southampton have that kind of sort of experience, and we're happy with the amount of benefit patients have, and they're extremely grateful for us. It is a high risk intervention, and people may end up being dying or being hospitalized for a long period of time. Just a bit of idea about the kind of interventions we have on offer. There's the good old-fashioned VATS. I'm just saying that because in the past it used to be going through the stenotomy and doing bilateral resection of lungs to reduce that residual volume. But now we have got into VATS, which is less invasive, and we do one side at a time, and we have better long-term results. And the best people, well, as I said, it will be the ones who have low exercise capacity. Sometimes we do a lung volume reduction as part of managing people with ongoing air leaks. So it's two birds with one stone. Glenfield is one of the places in Leicester, have been one of the places which have a big experience in lung volume reduction, and they developed a score. I'm just giving it here as an idea. This BFG, BMI, FEV1, and gas transfer, and they assign scores for each one of them. Again, people who are under or overweight, underweight will score high risk. If their transfer factor or their spirometry is below a certain level, they will again score high. And depending on that score, we give them a mortality, which in the worst group, who have the highest score, it can reach 17%. But in the lowest group, it can be as 0%. So as many of those factors can be improved, we obviously can't improve those, but we can improve on the nutrition at least. But this has been mainly for surgical LVRS, and we have found with non-surgical or invasive natural orifice treatment, we can push those, improve on those figures and reduce the risk further. So this is just to wrap around with some talk about natural orifice surgery. So endobronchial valves, EVVs, LVRS coils, which, as I said, is suspended, and in trials at the moment there's foam, and there is targeted lung denervation, which is more of a sympathetic denervation of, and I'll mention that briefly. Again, it's a trial. The valves, this is an examination, sort of a representation of how this is a pencil, and it's the size of the tip of a pencil and deployed. It's collapsed on itself. It's made of 19-0, and this thing has a one-way valve which allows the air out, but not in, which means that if you put it into the segmental bronchi, it will slowly empty the air out and reduce the volume of that part of the lung which you're excluding, to the point that it collapses completely. So to have this treatment, you need to make sure that the only source of air in that lung is the bronchus and the segmental bronchi. If there is another source of air, like a fissure, like where the lungs are joining here, for example, a lingula and of the upper lobe and the lower lobe, you see this gap there in the fissure. That gap means that even the air coming through the bronchus, if that excluded, doesn't stop the air from the lower lobe going back into the upper lobe. And therefore, this exclusive treatment is not going to work. So we have some fancy sort of software called STRATEX, Digital Assessment of Emphysema, which gives us variety of information about the degree of emphysema, the volumes of each lung, which we're going to try to treat, because obviously lung volume reduction means you need to reduce volume. So anything which is very small is not worth reducing or intervening upon. So the volumes, the degree of emphysema, and finally the amount of fissure integrity. So this black line here means that this lobe is completely separate from this lobe. Like there is a complete line of separation, which means that the only air supply to this lobe is through the bronchi, and putting the valves in those bronchi would exclude the airflow to it, so it should collapse. So this is a video which I'll see if it works. My apologies. We tried. Okay. Is that coming through, Hanad?
Yes, yeah, it is.
Okay. So basically, this is a view of the bronchi. You can see here what we just described in our first slide about the different airways. And then we have this delivery catheter, which when it goes in there, it basically allows you to put a sizing. So this thing has you might have heard Mr. Kamran Beg talking about sizing aortic valves. So we can size the valves which you need to put into this, and then choose the right valve, and then put it through this delivery catheter after taking the sizer out. You can see the thing comes in as a thin wrapped in device, but then as it comes out, it opens up and sits into the airway, and you can see the lips opening and closing. So air comes out from the airway, from the lobe, and then when it comes trying to go back, the two lips collapse on each other. So we basically go to that lobe and look at all the segmental bronchi there, usually 3 to 4 in the upper lobe, 4 to 5 in the lower lobe, and we size all of them and choose the appropriate size valve. There's about 5 sizes of valves, depending on the length and the width of the airway. We site them on the carina of that airway so that it doesn't shoot distally into the lung, and we have good contact between the valve and the wall of the bronchus. The more contact, the more secure the valve is. So that's why placing them is quite an important technical step in making sure they do their job properly. Oversizing and undersizing again have a problem. Either they leak from around the edges if they're undersized, or they don't open fully if they're oversized, and therefore they don't work. Okay, so we'll just stop that and go back to the presentation. Okay, you see the presentation again?
Yeah.
Okay, so these valves, obviously, it's a bronchoscopy. Patients just come in for a day. We used to do them a day case, but decided to keep the patients a bit more because of the risk of pneumothorax from sudden collapse. If you have a big part of the lung collapsing, you might end up tearing some of it off the chest wall, and that can cause an air leak. So, which can be up to 30%. So we decided now to keep the patients a bit longer, and the risk is quite high within the first few days of the treatment. They will have things like exacerbation, pneumonia, dyspnea, problems around the valves, valves being coughed out, other sort of small problems. So it's not without complication, but it has been very useful in pushing the boundaries in terms of who we treat, because it doesn't involve any surgery. The anesthetic is shorter, and therefore we have really expanded the criteria of patients we treat. Coils is one of the things which we try to, in Southampton and other centers around the UK for a few years, seem to have worked. And basically they crunch the lung, and you put them distally, and basically they crunch the lung, because this is actually placed somewhere there. And it's a thin wire that, as it comes out of its catheter, similar to the valve, it starts to coil on itself and pulls the lung away by wrapping it into a small bunch down here into the hilum, allowing the remaining bit of the lung to expand to fill up the space. So they come from behind. In this case, the lower lobe will come from behind and fill up the space crunched up by this by the deployment of the coils in the upper lobe. Finally, just talking about the targeted foam, I didn't find out because it's a study. It involves basically putting foams in these distal airways to collapse them and to cause an inflammatory reaction, which will basically cause atelectasis in bits of the lung. They've had mixed fortune. Some patients did very badly, and therefore they suspended for some time. Some patients did better, so that's why it's still a study. And then there is this targeted lung denervation, where basically you put a balloon with a heating probe in the orifice of the airway, where there's and basically you are performing a sympathectomy to stop the reactivity of the airways to the point that the vasospasm, which can happen in some varieties of COPD emphysema, is reduced. Again, it's a trial. It's not into main use yet, but again, it's a non-interventional, non-surgical, more interventional natural orifice treatment. So finally, just to wrap up, I've started training here when we used to have to cut the patient in half to get inside his chest and cut bits of his lungs, whether it's for cancer or lung volume reduction. Then we moved to keyhole surgery, video-assisted thoracic surgery, where we use few holes to put our instruments. And industry have designed long instruments to go down these holes, which are long and thin. And now we're doing things one hole, and we sometimes do them robotically. So again, long instruments and a lot of imaging with cameras. And now I am witnessing natural orifice surgery, where you don't need to make any holes. You just go through the natural hole to reach the target. And in this case, we're doing COPD, LVRS, but we are doing some lung cancer surgery by using that to navigate into these bits of the lung beyond the bronchi into the airway to sample them. And in Southampton, we're about to start an ablation program where we actually pass a microwave catheter into the lesion and basically overheat it to kill it. And that will allow us to treat people who are not fit for an actual, even a keyhole surgery. So I'll stop here and take any questions.